And now we'll move to the second talk, which will go to the other option of treatment, the medical treatment for obesity, and that's going to be delivered by my friend and colleague, Dr. Sami Kenz, who is practicing in UAE at Rashid Center for Diabetes Research, and he works as the endocrinologist lead in the center. Sami, the floor is yours.
Thank you, Dr. Salah. Good afternoon, everyone. It's my great pleasure and honor to be here in this conference, and again, I would like to thank the organizer for the kind invite. Dr. Amir, I think he made my job very easy, so probably I don't have much to say from management of obesity, but I'll focus mainly on the medical management of obesity. So he already touched on the guidelines, so for me, the guideline is still the same as before, but we could see his point with the change in a BMI and going with a lower BMI. Okay, so here's the outline for my lecture today. I always would like to start with a clinical scenario. So I love sharing some clinical case I managed in my practice. Then we'll talk briefly about the prevalence of obesity, and then talking about the obesity as a chronic disease and relapsing condition. And then what's the consequence and complication of obesity, and what's the benefit from weight loss. And then I'm focusing on the four medications: liraglutide 3 milligram, Saxenda, and then Contraved, it's a tablet, naltrexone and bupropion, and Wegovy, semaglutide 2.4 milligram, and then tirzepatide, Mounjaro, and then we have a conclusion. So I've seen this gentleman probably now about 3 years ago. Khalid, he is a 45 years old gentleman, Emirati patient. He presented to outpatient clinic in Rashid Center in Diabetes and Research in Ajman, mainly because of obesity and metabolic syndrome and pre-diabetes, sorry. He had a strong family history of type 2 diabetes. His BMI, as you can see, is 37.8. Blood pressure slightly elevated. HbA1c is 5.9% in pre-diabetes range. His LDL slightly elevated, total. So this is typical metabolic syndrome. I did oral glucose tolerance test just to confirm whether he had diabetes or not, and that came back normal. So as we always do, first we discuss about healthy lifestyle, diet and exercise. We refer them to the dietitian. So we always want to give the patient chance for behavioral change. We don't like to start medication from day one or starting bariatric surgery from the first clinic visit. So we always want the patient to make some behavioral change, okay? So we're giving him some few months to work in the healthy lifestyle and diet and exercise, but unfortunately he was not successful, and he came back after 3 months, gained some weight. And he said his main issue is mainly that he's just eating when he's really relaxed at home, and it looks like he's problem with the craving for food. So he doesn't want injection, and at that time, we are luckily in the center, we have Contrave, which is a combination of naltrexone and bupropion. So we started him on that, and he came back after a few months with a very successful. I thought if he was failing with a healthy lifestyle and diet and exercise in the first 3 months, probably he will not, but he's actually with the tablet, he was able to tolerate it very well, and he managed to lose weight. He lost 12 kilograms in weight, so that's equal to 9.6% of his body weight. So his weight came down from 125 to 113, his BMI is down, blood pressure also improved, so all his other metabolic parameters all improved. So you could see his HbA1c from 5.9 to 5.7, and even his LDL and triglyceride all improved. Unfortunately, after 6 months, the drug was stopped because we have an availability issue. So he had it for 6 months, and he did very well. And that's sometimes what happened with patients with obesity. When you give them that first push, you give them either medication, they become very motivated. They lose weight, whether it's 5 or 7 kilos, they don't want to go back. So he continued with his healthy lifestyle, although the medication is not available and was stopped, but he managed to lose weight with the tablet, without the tablet, sorry. And then he came 3 months after without medication. He is actually now lost more weight, and his total body weight loss is almost 14.4%, which is really good. So his BMI down, still obese, but come down from 38 to 32, and his HbA1c down to 5.5. So everything normalized. So quite happy with him. I have lost the contact with this patient. I don't know what happened, but this is from 2 years. So that's the story. Till then, he was doing really well. So what's obesity? Obesity is a chronic relapsing disease, and that's really important, okay? Obesity is not acute condition. We give treatment only for a few months and 1 year and stop. It is a chronic disease, and that's why patients need to be on a medication for a longer term. The classification of obesity, as you can see here on the table, when the BMI more than 30, we can classify it to class 1, 2, or 3, depending on the BMI. If between 30 to 35 is a class 1. If it is 35 up to 40 is a class 2, 40 and more it's a class 3. But as Dr. Amr mentioned, in Asian population, its BMI is slightly different, so we have to be careful with that. Okay, the prevalence of obesity is increasing all over the world. As you can see in the Middle East and North Africa, the prevalence of obesity, it can be anything between 20 to 40%. So it's really high, quite high. So the number of people diagnosed with obesity is predicted to increase by 2030 up to 1,000. You could see this is 1.5 billion. So at the moment, I think there is around 1 billion people diagnosed with obesity. By 2030, 1.5. Okay, obesity is associated with the reduced life expectancy. So when you have a BMI more than 30 to 35, your life expectancy will reduce by 2 to 4 years. When the BMI more than that, 40 to 50, the life expectancy will reduce by 8 to 10 years. So believe it or not. So obesity itself will reduce life. And that's, we don't want to get patients scared, but these are the facts. Obesity contributes to a lot of other medical conditions. Very importantly, can affect the patient well-being. Okay, patients with obesity, they're unlikely to have depression. There is a reduce of their self-esteem, associated with stroke, increased intracranial pressure, hypertension, diabetes, dyslipidemia, all of this, polycystic ovary syndrome, reduced fertility, obstructive sleep apnea, hypoventilation, you name it, back pain, osteoarthritis, and increased cancer. So people with obesity, just having obesity, this make especially colorectal cancer and breast cancer. So obese patients, they are at high risk of cancer. So this is illustrated here. So the chance of cancer is increased between 1 to 7%, especially esophageal, stomach, and liver and kidney cancer and colorectal cancer. 3 to 7-fold increase prevalence of diabetes as compared with normal populations, and 55% increased risk of depression as compared with normal population, and 2-fold increased risk of coronary heart disease and stroke. So what are the possible etiology? I think we heard about this yesterday in the first lectures. There are a lot of multifactorial causes of obesity, but some of them physiological, behavioral changes, environmental and genetic and epigenetic factors. There are so many causes for obesity. I have to say obesity is being recognized by all society. It's a chronic disease. So this this is a fact, and especially for our commissioner, when we start treatment, we have to start the treatment and continue the treatment because the disease is a chronic. So if you stop the medication, the patient will regain weight. Okay. Obesity is associated with a lot of other comorbidity. So when this, according to this study, you could see with a higher BMI, will be increase in the triglyceride, increase in the total cholesterol, and increase in LDL cholesterol, and reduction in high HDL. Diabetes, especially if the BMI 35. So you could see when the BMI 35 or more, the chance of having diabetes is almost 90%. So anything more than 80%, so very high. And yesterday in my first presentation about diabetes remission, if you lose 15 kilograms in weight, there is a very high chance, more than 80%, you get your diabetes in remission. So there is a clear correlation between diabetes and obesity. I'm not going to talk in detail about the guidelines, but our still medical guideline, if we are overweight, healthy lifestyle, diet and exercise, but when the BMI more than 25, okay, that's when BMI 30 at least, then that's the indication for pharmacotherapy. 27 and more, up to 30, with at least one comorbidity, that's indication for pharmacotherapy. So that comorbidity could be hypertension, could be diabetes, pre-diabetes, obstructive sleep apnea. So all of these are comorbidity. If you have a BMI of 27 with any one of these, then it's indicated for tablet. BMI 40 and more, that's indication of bariatric surgery, but still the guideline, if 35 and with comorbidity, then it's indication for bariatric surgery. This is the result from meta-analysis of 6 randomized controlled trial. That's what I just mentioned, is obesity or losing weight is very difficult to maintain. There is a high chance you will regain weight after 1 year. So according to this meta-analysis, the data showed that patient will lose weight in the first year. So the weight is down, there's maybe 10, 13 kilograms in weight, but after 1 year, they will regain weight, as mentioned here. So comparing patient with very low diet, very low calorie diet, behavioral diet, they all regain weight after 1 year. So they're maintaining the weight first year, losing weight, significant amount of weight, but after 12 months, they will regain weight. So what's the pharmacological options for management of obesity? I just put them here in a table. I think orlistat is a very weak drug, but in some patients can work. It can give you anything between 5 to 10%, but in general, I've seen this drug, you just lose maybe 3 to 5 kilos, so maybe 3%, but this is what's been written is 5 to 10. Liraglutide or 3 milligrams Saxenda, anything between 8 to 10%. Naltrexone biberon, anything between 8 to 12%, like what happened with our patient, he lost almost 14% of his body weight. Semaglutide 2.4, Wegovy, you can lose up to 18% of your body weight. And look at tirzepatide or Mounjaro, it's like almost bariatric surgery, Dr. Amir. So 22.5%, he's busy. Okay, thank you. So 22.5 with tirzepatide. And recently we have got phentermine and topiramate. It's licensed in UAE, but I think it's not, but it will become very soon available, hopefully everywhere, even in other countries in the Middle East. You could lose 12 to 14% of body weight. So all of these medications are indicated as an adjunct to diet and healthy lifestyle and diet and exercise with a BMI of 30 and more, or 27 with at least one comorbidity. Those comorbidities could be diabetes, hypertension, pre-diabetes, dyslipidemia, or maybe obstructive sleep apnea. This is need updating. Bariatric surgery, with bariatric surgery, you can lose 24 to 38%, especially after gastric bypass. But with medication, we used to say 5 to 10% of body weight, but now 5 to 20, because with Mounjaro now it's 22, so we could say from 5 to 22%. What's the benefit of weight loss? And that's why the guideline here recommending 5 to 10% of body weight, because only you will get the benefit if you lose at least 5% of body weight. So if you lose 5 to 10% of body weight, there is a high chance you have a remission of diabetes or improvement in the glycemic control, reduction in cardiovascular mortality, okay, improvement in the lipid profile, improvement in the blood pressure, and improvement even in symptoms of obstructive sleep apnea, and most important, improvement in the quality of life in general. We talked about direct trial yesterday. When you're following a very low-calorie diet and you lose at least 15 kilograms of weight, then there is a high chance of 86% of diabetes remission. So let's go through these four drugs briefly on what's the evidence and data behind them. So liraglutide 3 milligrams Saxenda was being studied in the SCALE program in the different type of population, in group of population and group of population with obesity and pre-diabetes, and also in population with obstructive sleep apnea. And that's compared with the placebo, and look at that. So in the dark blue, that's patient on liraglutide 3 milligram. They're managing to lose anything between 6 to 8% of body weight as compared with the placebo in the different type of population, whether it's the obesity or diabetes or patient with obstructive sleep apnea. And also, it's associated with improvement of all other metabolic parameters, including systolic blood pressure will be reduced by 4 to 5 millimeter mercury, and improvement in the lipid profile in general, like LDL, triglycerides, so all improvement. This showed how HDL and LDL, and HDL will be increased, and LDL and very low density lipoprotein reduced. What are the side effects of liraglutide? As with all other GLP-1, nausea and vomiting, GI side effect, that's the very common side effect, but they are all similar to other GLP-1. The risk of pancreatitis and medullary thyroid carcinoma is very rare as compared with all other GLP-1. Let's move to Wegovy. Wegovy, it is semaglutide 2.4 milligram. It is more beneficial and very effective in weight loss. So semaglutide 2.4 or Wegovy is indicated in management of obesity and has got the license for obesity as an adjunct to diet and lifestyle in a BMI of 30 and more, or 27 with one comorbidity. Wegovy or semaglutide 2.4 has been studied in the STEP 5 program compared with the placebo, and you could see how the percentage of body weight reduction up to 18% compared with the placebo. What about other cardiometabolic parameters? You could see very significant reduction in all other cardiovascular parameters. Weight circumference, systolic blood pressure, diastolic blood pressure, and even inflammatory markers. So C-reactive proteins, we know with most of GLP-1, but look at that C-reactive protein reduction. So all cardiovascular metabolic parameters being reduced. You have seen this slide already of tirzepatide by Dr. Wiam. So it's licensed for both diabetes and obesity. The indication for obesity as a monotherapy can be when metformin is inappropriate or due to complications, or in addition to other oral hypoglycemic agent. Tirzepatide or Mounjaro, it's licensed for obesity by itself, okay, if as an adjunct, of course, to diet and healthy lifestyle, with a BMI of 30 and more, or 27 and more in presence of at least one comorbidity. We know the mechanism of action of tirzepatide and all GLP-1. It's a combination of GLP-1 and GIP. The GLP-1 will delay gastric emptying time and also reduce the appetite. And more importantly, due to the GIP effect, it has an effect on subcutaneous white adipose tissue by increasing the insulin sensitivity and increased lipid buffering capacity and increased storage capacity, and this will all lead to lose weight. This is I think this is first time in any medication showed this very massive reduction in the body weight. So as compared with the placebo, the percentage of body weight reduction can reach up to 22.5%. This is you could see in dark red, that's 15 milligram of tirzepatide. You could lose up to 23.5 kilogram in weight, so almost equal to bariatric surgery. All other metabolic parameters also reduced, including systolic blood pressure, diastolic blood pressure, systolic around 7 to 8, diastolic 4 to 5, triglyceride, reduction in LDL cholesterol, and yesterday I explained about the reversion of normoglycemia. So there is tirzepatide, you can achieve remission of diabetes and getting the HbA1c less than 5.7. Moving to Contrave, naltrexone piperon, it's working in very complex system in the mesolimbic reward system and hypothalamus that help patient to lose weight. Piperon is indicated for treatment of depression, and naltrexone is indicated for alcohol dependence. They work in a synergistic effect, helping patient to lose weight. They both licensed and they had the FDA approval since 1984. Naltrexone is opiate receptor antagonist, naltrexone opiate receptor antagonist, and piperon is a dopamine neuroepinephrine reuptake inhibitor. They both work in a synergistic way to help patients to, having less craving for food and reduce their appetite. Naltrexone and piperon has been studied extensively in different group of populations, including patients with, a healthy lifestyle and diet and exercise, and group of patients in diabetes. So different type of population, group in just diet and life, and other group in diet and exercise and healthy, intensive exercise, and other group, they have diabetes. And all of these groups showed a clear reduction in body weight as compared with the placebo. So you could see here in the yellow side that a patient can achieve almost 12% reduction in body weight as compared with the placebo. These are the metabolic parameters also reduced, but for unexplained reason, there's no much difference in LDL cholesterol, but the triglyceride and triglycerides is reduced and HDL cholesterol improved. Nausea and vomiting, headache are the common side effect of naltrexone and piperon, and also there is a high chance of discontinuation, or it's not discontinuation, it will not be very effective in 1/4 of the patient. So sometimes it doesn't work. So you have to select your patient for this, especially for those patients for craving for food that work very well with them. That's again, just to show you that the different agents for obesity and the different efficacy, comparing all of them together. At Rashid Center, we have a pathway how to manage obesity from day one when they're presenting to the clinic. What's the initial assessment, and then the journey of the patient through the center, and then make sure when we refer to the bariatric surgery, but we always ensure that the patient, they had a healthy lifestyle, diet and exercise, and they had the trial of medication for a good period of time. We don't normally, at least 6 months. So in some places they say 12 months, but at least for 6 months. And then we refer to bariatric surgery if all failed, if the patient not able to achieve 5 or 10% of their body weight. So, ladies and gentlemen, just to conclude, obesity is a chronic relapse condition that impairs health. There are hormonal, genetic, and epigenetic factors that promote weight gain. Realistic approach of losing 5 to 10% of body weight can lead to improvement of all metabolic parameters. Behavioral modification remains the cornerstone of treatment. We should always start with behavioral healthy lifestyle and diet first. Pharmacological treatment is indicated after healthy lifestyle and diet and exercise. And very importantly, when we start the medication, we continue. The patient needs to continue the medication to maintain weight loss. With that, I would like to thank you for your attention. Thank you.